talk by Professor Dr. Attila Kovacs. I hope I pronounce right. Electrochemotherapy, the new kid on the block.
Gentlemen, I'm pleased to give you the lecture on the use of electrochemotherapy in hepatobiliary malignancies. Thank you for the invitation. It is already well known that local ablations in the liver significantly improve progression-free survival as well as overall survival. The CLOCK trial in hepatic metastases of colorectal cancer demonstrated an improvement of progression-free survival up to 12-fold and in overall survival up to 4-fold. Further evidence is that local tumor control after percutaneous ablation is not anymore inferior to open surgical ablation, for example, in patients with colorectal liver metastases, which is why the authors conclude that percutaneous procedures should be preferred because they are less invasive. Today we have a broad armamentarium of percutaneous image-guided ablation procedures for the liver at our disposal. The black ones can be considered as outdated. With so many options, one can assume that we are approaching a period of perfect tools and unfocused targets. In the following, we will take a closer look at how ECT complements this armamentarium. But what is exactly this new kid on the block? What is ECT? What is special about it? ECT is not a thermal ablation, rather chemoablation that enhances local efficacy of a chemotherapeutic drug using electroporation. Therefore, is ECT able to overcome some of the limitations of thermal procedures and holds great potential for special indications. ECT has three anti-tumor effects: the death of the mitotic tumor cells, tumor cell ischemia, and the stimulation of the immunogenic response. The chemotherapeutic substrate of ECT is bleomycin, a hydrophilic, slow to non-permeant cytostatic drug, and by the way, also an antibiotic. Unfortunately, bleomycin is a very large molecule that cannot pass through the intact tumor cell's membrane or can only do so to a limited extent. This is why electroporation is used as a Trojan horse to smuggle bleomycin into the tumor cells. Electroporation is a well-known technique in molecular biology to increase temporarily the membrane permeability by a discharge current. It enables that non-permeant drugs pass the membrane from the extracellular into the intracellular space. ECT, like other percutaneous image-guided ablations, requires precise planning. In the pre-interventional planning, the following parameters are determined: the number of the electrodes, the length of the penetration channel, the length of the active tip, and the distance of the electrodes to each other. The required supporting tools for a percutaneous ECT are a planning software to determine optimal position of the electrodes, a navigation system or fluoroscopy for needle guidance, and intra-procedural imaging to control the target coverage and also the parallelity of the electrodes. Furthermore, you need a generator and electrodes with different shaft length and active tips. For tumor coverage, the optimal distance between the electrodes as well as the parallelism of the electrodes is crucial. ECG triggering is indispensable for safe discharge in the refractory phase of the heart. If the target lesion is larger, it is recommended to define 2 or more subdomains and to treat them one after the other. As the electrical discharges are accompanied by strong jerks, a general anesthesia is recommended. Here you can see very well the perfect parallelism of the electrodes, which is a prerequisite for a homogeneous electroporation. This example of a very large marginal recurrence after hemihepatectomy is a good demonstration of the performance but also the advantages of the electrochemotherapy. On the one hand, you have a perfect ablation already 2 days after the procedure. And this although the tumor has a diameter of almost 10 centimeters. Last but not least, it is also remarkable that the surrounding vascular structures, such as portal veins, branches, hepatic veins, and the transhepatic inferior vena cava, remained intact despite the ablation margin in the immediate vicinity. Triggered and motivated by the excellent clinical experience, we have scientifically evaluated the performance of percutaneous ECT. I would like to share these results with you. This study evaluated the performance of ECT in primary and secondary liver malignancies. The impressive results are as follows. We achieved an objective response of 85.7%, a mean progression-free survival of 9 months, mean overall survival of 11.3 months, and it was very interesting that the progression-free survival and overall survival were independent of primary histology, and the effectiveness of ECT was independent of the localization of the target. It could be distant, close, or adjacent to vital structures. The second study compared the performance of different well-established ablation procedures in the liver: radiofrequency, microwave, cryotherapy, interstitial brachytherapy, and last but not least, electrochemotherapy. Excellent tumor control was demonstrated for ECT in several primary and secondary liver malignancies. However, it was notable that the vast majority of the target lesions treated with ECT were very large and were located in challenging locations. In many cases, ECT was the only alternative because thermal ablations were unsuitable. Another important finding is that ECT has a positive immunomodulating effect in cutaneous melanoma metastases. For example, the combination of ECT with checkpoint inhibitors, in this case anti-PD-L1 monoclonal antibody pembrolizumab, resulted in a superior local progression-free survival, systemic progression-free survival, and overall survival compared to pembrolizumab monotherapy. Well, summing up the indications for and advantages of ECT, first of all, ECT is not a thermal ablation, while it can outperform the limitations of thermal local ablative therapies. It is able to preserve collagenous structures. Bleomycin has a toxicity regardless of the histology. Using ECT, we achieve good local tumor control. The technique is well tolerated and it's repeatable and can be added in between the systemic cytotoxic cycles. ECT is suitable for larger and irregularly shaped targets in the vicinity of vulnerable structures. It is also feasible for entities with low radiation sensitivity, and it might be used also in locations where pain after thermal ablation is inevitable. With so many advantages, it's obvious that ECT is not only the new kid on the block, but a serious gap filler and a game changer. I would like to draw your attention to a new register study of the Cardiovascular and Interventional Radiological Society of Europe, CHERSA. The study is called RESPECT. It's the registry on percutaneous electrochemotherapy. And the objective of this study is to expand our understanding of percutaneous ECT for the management of primary and secondary liver malignancies regarding its effectiveness, safety, and impact on life quality in a large and diverse population of patients. Thank you very much for your attention.
Okay, I think we're going to move to the next speaker.